Good morning, everyone. This is Amanda Cohn, and welcome to the August 30th virtual ACIP meeting. The slides for today's ACIP meeting are on the ACIP website and additionally are available for ACIP voting liaison and ex officio meeting members through the share file link. Next slide. These are a few notes on the meeting logistics for those of you who are listening on the Zoom line. Of note, the ACIP members will not have their camera on during the discussions except for prior to the vote. And during the voting session, ACIP members will turn their video on. Next slide. I'd like to introduce, with pleasure, two of our three new ACIP members. We will more formally introduce Dr. Cineas and Dr. Brooks to everybody at a regular meeting, but these two new members are approved and will be participating in today's meeting and vote. Dr. Sybil Cineas is a Med-Peds and director of the residency program at Brown University and Providence, Rhode Island. And Dr. Oliver Brooks is a pediatrician and with Watts Healthcare Corporation in Los Angeles, California. Both of these new members have extensive experience in immunization and in healthcare, and we will provide more information on these two members and let them introduce themselves at the next meeting. Next slide. So today's meeting, we will have a public comment session. It will occur this morning at approximately 11:15 Eastern Time. We have opened the docket for members of the public to request speaking at this meeting, and then we held a random lottery system to determine who would be given time to speak. Additionally, we do have written public comments available via regulations.gov. If you go to regulations.gov and use docket number CDC /2021-0089, you can submit a written public comment, and we encourage individuals to do that. The ACIP members do have access to the docket and do review these public comments. Next slide. Members of the ACIP do agree to forego participation in certain activities related to vaccines during their tenure. We have issued limited conflict of interest waivers. At the beginning of each meeting during roll call, ACIP members will state any conflicts of interest, and they will repeat any conflicts of interest during the vote. Next slide. I'm now going to turn the meeting over to Dr. Lee, our chair, to take roll call, beginning with the ACIP members and ex officio members. And please remember to announce your conflict of interest to the voting members. Dr. Lee?
Thanks, Dr. Cohn. I will now take roll call, starting with ACIP members and then our ex officio members and liaisons. For the ACIP members, I'll ask that you state your name, affiliation, and whether you've had any conflicts of interest. So we'll start with Dr. Alt.
This is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas, and I do not have any conflicts.
Thank you, Dr. Alt. Ms. Bata?
Good morning, Lynn Bata, immunization clinical consultant at the Minnesota Department of Health, and I have no conflict.
Thank you. Dr. Bell?
Beth Bell, clinical professor, University of Washington, no conflicts.
Thank you and welcome. Dr. Brooks?
Dr. Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation, Los Angeles. I have no conflicts.
Thank you, Dr. Brooks. Dr. Chen?
Gilbert Chen, Professor of Medicine at the University of Maryland School of Medicine.
Do you have any conflicts, Dr. Chen?
Oh, I'm sorry, no conflicts.
Thank you, Dr. Chen. Dr. Cineas?
Good morning, Dr. Sybil Cineas. I'm an associate professor of medicine and pediatrics and a primary care physician at Warren Alpert Medical School of Brown University, and I have no conflict of interest.
Thank you. Dr. Daly?
Good morning, Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Cotton?
Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Disease at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you, Dr. Cotton. Dr. Long.
Sarah Long, good morning. I'm Professor of Pediatrics and Pediatric Infectious Diseases at Drexel University College of Medicine in Philadelphia, and I have no conflict.
Thank you. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you, Ms. McNally. Dr. Paling.
Good morning. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflicts. Thank you.
Thank you. Dr. Sanchez.
Morning. I'm Pablo Sanchez. I'm Professor of Pediatrics and in the divisions of Neonatology and Pediatric Infectious Diseases at Nationwide Children's Hospital, The Ohio State University in Columbus. I have no conflict. Thank you.
Thank you, Dr. Sanchez. Dr. Talbot?
Good morning. I am Dr. Talbot. I'm an infectious disease physician for adults at Vanderbilt University Medical Center, and I have no conflicts. Thank you.
Thank you. And I am Grace Lee. I am at Stanford University School of Medicine and Stanford Children's Health, and I have no conflicts. With that, I think we are done with roll call for our ACIP members. We'll move on to our ex officio and liaisons, and I will announce the organization name, and then please indicate if you are present and your first and last name as you represent your organization. We will start with our colleagues at the CDC.
Good morning. This is Melinda Horton from the National Centers for Immunization and Respiratory Diseases.
Thank you. Center for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance for the Centers for Medicare and Medicaid Services.
Thank you. Food and Drug Administration.
Good morning. Doran Fink from the U.S. Food and Drug Administration Office of Vaccines.
Thank you. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, HRSA.
Thank you. Indian Health Services. We have our colleague on from Indian Health Services. We'll come back to you. National Institutes of Health.
Morning, John Weigel, National Institute of Allergy and Infectious Disease, National Institute of Health.
Morning, thank you. Office of Infectious Disease and HIV/AIDS Policy.
Morning, David Kim, representing the Office of Infectious Disease and HIV/AIDS Policy, Office of the Assistant Secretary for Health.
Thank you. We will move on to our liaison representatives, American Academy of Family Physicians.
Pamela Rockwell, American Academy of Family Physicians, present. Thank you.
Thank you. American Academy of Pediatrics.
Good morning, everybody. Bonnie Maldonado, Professor of Global Health and Infectious Diseases at Stanford University and Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you, Dr. Maldonado. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Hey, Dr. Lee, Marie Michelle will miss roll call this morning.
Thank you. American College of Health Association.
They're also not available this morning.
Thank you. American College of Nurse Midwives.
Present, Pamela Meharry.
Thank you. American College of Obstetrics and Gynecology.
Good morning. It's Dr. Linda Eckert at University of Washington in Seattle, present for American College of Obstetrics and Gynecology.
Thank you. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine, Affiliate Associate Professor at Florida Atlantic University, also in General Internal Medicine Private Practice, representing American College of Physicians. Thank you.
Thank you. American Geriatric Society.
Good morning, Ken Schmader for AGS.
Thank you, Dr. Schmader. America's Health Insurance Plans.
This is Bob Gluckman. I'm the Chief Medical Officer for Providence Health Plans in Portland, Oregon. Present. Thank you.
Thank you. American Immunization Registry Association.
Good morning. This is Rebecca Coyle representing the American Immunization Registry Association.
Thank you. American Medical Association.
Sandra Freihofer, General Internal Medicine in Atlanta, Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Perfect. American Nurses Association.
Chad Riddle, President, representing the ANA.
Thank you. American Osteopathic Association.
Stan Grog, Professor Emeritus at Oklahoma State University, representing the American Osteopathic Association. Good morning. Thank you.
Morning, and thank you. American Pharmacists Association.
Good morning. This is Steve Foster representing the APHA.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Morning. Association for Prevention, Teaching, and Research.
This is Dr. Paul McKinney, Professor, School of Public Health and Information Sciences, University of Louisville.
Thank you. Association of State and Territorial Health Officials. Association of State and Territorial Health Officials. We'll come back. Biotechnology Innovation Organization.
Hello, good morning. Phyllis Arthur for Bio. Thank you.
Some of the medications are multiple.
Good morning, thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, representing CSPE.
Thank you. Canadian National Advisory Committee on Immunization.
Morning, Matthew Tunis, Executive Secretary to the Canadian National Advisory Committee on Immunization, here on behalf of the chair.
Thank you. Infectious Disease Society of America.
Good morning, Jeff Duchin, Public Health, Seattle-King County, and Professor in Medicine, Division of Infectious Diseases, University of Washington, Seattle.
Thanks, Dr. Duchin. International Society for Travel Medicine.
Good morning, Elizabeth Barnett for ISTM.
Good morning, Dr. Barnett. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACHO, present.
Good morning, Dr. Zahn. National Association of Pediatric Nurse Practitioners. She may be late, but will be joining later. National Foundation for Infectious Diseases.
Good morning. This is Marla Dalton, representing NFID.
Thank you. National Medical Association. Do we have anyone on from the National Medical Association?
Good morning. This is Pat Whitley Williams.
Good morning, Dr. Whitley Williams. Thank you for joining. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary, representing state.
Morning. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Hi, it's Amy Middleman, representing SAM.
Thank you. Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Drees, Chief Infection Prevention Officer and Hospital Epidemiologist for Christiana Care, representing SHEA.
Morning. Thank you. Do we have a colleague on from Indian Health Services? Okay. Are there any other organizations or ex officios that I had missed? Perfect. With that, Dr. Cohn, would it be okay if we move on to the next session?
Yes, let's go ahead.
Okay, thank you. So before we start, I'd actually like to make a few brief comments to the committee and to the public. I wanted to just highlight that today we will be focusing on updating the recommendations for use of the Pfizer-BioNTech COVID-19 vaccine now that it has received full licensure from the FDA. Later in the day, we will also be hearing an update from the COVID-19 vaccines work group on the topic of booster doses, and we'll continue our ongoing discussion that we started on August 13th of the PICO question and key domains in ACIP's evidence to recommendation framework. Given the state of the pandemic and the importance of vaccines as a tool to address this pandemic, I just wanted to remind our colleagues and the public that the ACIP will continue to follow our usual processes regarding booster doses as we do for every other ACIP recommendation. After the FDA has the opportunity to carefully review the data submitted by the companies on booster doses, ACIP will incorporate any updated data into its deliberations and will vote on recommendations for future use of boosters in the U.S. civilian population. We do anticipate having another ACIP meeting on this topic in the very near future. I also wanted to take the opportunity to thank our ACIP members, our ex officio members, and our liaisons for their continued dedication and service to this committee. And especially would like to take a moment to thank Dr. Rochelle Walensky, Dr. Amanda Cohn, the entire ACIP Secretariat team, and all of our CDC staff and colleagues for working around the clock to ensure that we have the data needed to support a robust decision-making process. During today's meeting, I will invite individuals to contribute to the discussion. As usual, please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. And if you wish to respond to a particular comment or question, please indicate this electronically with a thumbs up. And in today's first COVID-19 session, we'll start with Dr. Matt Daly, who will provide an introduction, followed by a presentation from our Pfizer-BioNTech team. Dr. Daly?
Great. Thanks so much, Dr. Lee. So I'm introducing the session today on behalf of the ACIP COVID-19 Vaccines Work Group. A few introductory comments. Last week, the number of individuals hospitalized with COVID-19 in the United States exceeded 100,000. And this is the highest level that we've seen since the peak incidence in January of 2021. And today we'll be, among other things, grading the quality of the evidence regarding the use of Pfizer-BioNTech COVID-19 vaccine. And just to frame this discussion, when considering recommending a licensed vaccine for use, never before has the ACIP made such recommendations with such a breadth and depth of information that we're going to consider today. There were at least 680,000 vaccinated individuals who contributed to the time under study in the observational studies that we'll review today. And that's in addition to the more than 40,000 enrolled, of whom more than 22,000 were vaccinated in the phase 3 clinical trials. Next slide. So on this graph, we're looking at daily trends in the number of COVID-19 cases in the United States. The number of total cases during the pandemic in the US has been more than 38 million cases reported. And as you can see, since nadir in June of 2021, cases in the United States have risen quite sharply. Next slide, please. This graph shows daily trends in the number of COVID-19 deaths in the United States. There have been more than 600,000 individuals in the US who've died from COVID-19. And more than 1,000 individuals are dying each day from COVID-19 in the US. And with safe and effective vaccines readily available in the US, at this point in the pandemic, death from COVID-19 is largely vaccine preventable. And this observation that I just made is supported by data that we're going to see later in presentations this morning. Next slide, please. So to orient you to the figure here, we're presenting age-adjusted weekly COVID-19 associated hospitalization rates among adults by week of admission, and these are data from COVIDNet for the time period of January 24th through July 17th of 2021. And the y-axis is the rate per 100,000 population. The lower bar shows the hospitalization rate in fully vaccinated. The upper shows the hospitalization rate in unvaccinated. And so as you can see, the unvaccinated rate is 16 times greater than the vaccinated rate. I should note that the shading at the right-hand side is data from July, which is preliminary. But what this shows, this to me seems to be a strong indication that the current epidemiologic curve that we're seeing is really a reflection of failure to vaccinate, not vaccine failure. Next slide, please. So I want to update the full ACIP on the COVID-19 vaccines work group activities in August of 2021, since we last met together. The work group has heard a number of safety updates, including from VAERS and from VSD, and we'll hear some of that data today. In addition, the work group has been reviewing in detail considerations around the use of Pfizer-BioNTech COVID-19 vaccine under full FDA licensure. And this has included reviewing in detail updated safety and efficacy data from the clinical trial, a detailed review of risk-benefit assessment, and this has had a particular focus on the issue of myocarditis. Then the work group has also evaluated all of the strength of evidence, which we call GRADE. So the explicit formal evaluation of the strength of evidence, or GRADE. We've also reviewed the evidence to recommendations framework, which we'll also hear about today. And additionally, in August of 2021, the work group has discussed in detail considerations for booster doses of COVID-19 vaccines. And this has included reviewing real-world vaccine effectiveness studies, and these studies are from the US and abroad. And the work group has focused in particular on what's known about hospitalized cases post-vaccination or breakthrough infections. Next slide, please. So here's the work before us today. First, we'll hear from Dr. John Perez at Pfizer, who's going to review BNT-162b2 COVID-19 vaccine BLA safety and efficacy data. Dr. Perez's comments will be then followed by a public comment period. After the public comment period, we'll hear from Dr. John Su at the CDC, who will provide a safety update on COVID-19 vaccines from VAERS. Following Dr. Su's presentation, we'll hear from Dr. Nicola Klein from Kaiser Permanente, Northern California. She will review safety data from the Vaccine Safety Data Link, or VSD. Following Dr. Klein's presentation, we'll hear from Dr. Grace Lee, who in addition to being the ACIP chair, is also the chair of VAST. VAST is the Vaccine Safety Technical Work Group, and she'll provide a vast assessment of the safety data for COVID-19 vaccines with a particular focus on Pfizer-BioNTech 19 vaccine. Following this, we'll hear from Dr. Hannah Rosenblum. And Dr. Rosenblum's presentation will be similar to what the ACIP has seen before in the context of reviewing detailed information about individual risk-benefit with updated vaccine effectiveness and safety data. Following Dr. Rosenblum's presentation, we will have a short break. And then after that, we'll hear from Dr. Julia Gargano from the CDC, who will review, again, it's the explicit formal review of the quality of the evidence regarding Pfizer-BioNTech COVID-19 vaccine. And then following Dr. Gargano's presentation, we'll hear from Dr. Kathleen Dooling, who will review all of this in the context of the evidence to recommendations framework. And then following Dr. Dooling's presentation, there will be a vote. And then following the vote, we will hear from Dr. Sarah Oliver, who will review considerations for booster doses of COVID-19 vaccines. Next slide, please. So I'd like to offer my sincere thanks to the COVID-19 vaccines work group, who's been meeting, very frequently. It's been once a week or even several times a week. That includes all of the ACIP members, Dr. Beth Bell, Dr. Grace Lee, Dr. Kip Talbot, Dr. Oliver Brooks. In addition, I'd like to thank the ex officio and government members, the liaisons and the consultants, and the outstanding leadership of our CDC leads, Dr. Sarah Oliver and Dr. Kathleen Dooling. Next slide, please. And then I'd also like to offer my sincere thanks and the sincere thanks from the COVID-19 vaccines work group for all of the CDC participants who've been contributing sort of countless hours to preparing the materials that the vaccines work group reviewed and that the ACIP will review today. Next slide, please. That concludes my introductory comments, and I'll turn it back over to you, Dr. Lee and Dr. Cohen.
Thank you. I think we can move directly to Dr. Perez's presentation.
Good morning. Can you hear me, please?
Yes, we can. Thank you.
My name is Dr. John Perez, and today I'm honored to present the COVID-19 safety and efficacy data with the data cut off of the 13th of March, 2021. Slide, please.
You have to click on this. There you go.
Due to time constraints today, I'm going to focus the discussion on a high-level overview of long-term safety analysis for individuals 16 years of age and older. I'll discuss adverse events of special interest, efficacy update. I'll talk about the sequence data on all our COVID-19 breakthrough cases, and I'll also present pregnancy data through the cutoff date. Not covered due to time constraints, but covered in this presentation will be information on HIV participants, individuals who are positive or negative at baseline for SARS-CoV-2, individuals who had more than one episode of COVID-19 cases, and placebo recipients who developed COVID-19 and then received a vaccine. So here's an overview of the study. 2 doses were given 21 days apart in approximately 46,000 participants. Reactogenicity data by eDiary was obtained 7 days after each dose. Non-serious AEs were collected through 1 month post-dose 2. Serious AEs were collected through 6 months post-dose 2, and deaths were recorded throughout the study. As you know, the vaccine became available while the study was ongoing, and subjects were unblinded, so placebo subjects could get vaccinated. So for individual subjects, we have a blinded placebo-controlled follow-up period and an open label follow-up period, as shown. While the data were refreshed from dose 1 to 1 month post-dose 2 in the BLA, all conclusions, especially about reactogenicity and lymphadenopathy, remain the same. I would add that the reactogenicity profile of participants with HIV were similar to what we saw in the non-HIV population. I will not discuss further here, but I could answer questions if needed. Today, I'm going to focus on safety with longer-term follow-up time, especially for those with at least 6 months of follow-up time. But note that some of the follow-up time is placebo-controlled and some is open-label. For the open-label period, we report all the safety data for people originally randomized to vaccine and those originally randomized for placebo. Please note that when placebo subjects were vaccinated, we saw the same reactogenicity and lymphadenopathy safety profile we saw in those originally randomized to vaccine. Let's discuss follow-up time. Here you see the follow-up time after dose 2 in individuals 16 years of age and older. If you look at the originally blinded placebo-controlled follow-up period, you can see that about 51.1% had between 4 and 6 months of follow-up, and an additional 8.1% had greater than 6 months of blinded follow-up time. If we look at it from a total exposure from dose 2 to cutoff date, you can see that 54.5% or over 12,000 individuals had greater than 6 months of follow-up time. We spend a moment on demography. The demographics were very similar to what's been presented previously. Roughly, there were equal numbers of males and females. Predominant race was white. Up to a third were Hispanic or Latino, and anywhere from 70 to 80% were from the United States. So let's now focus on safety, and this is adverse events to the unblinding date. Here you see the overall adverse events from dose 1 to an unblinding date. On the y-axis, you see the proportion of subjects who reported at least one adverse event. And on the y-axis, you see various categories of adverse events. And this is essentially the same pattern that we saw with the EUA. So you see that the vaccine group has a higher proportion of adverse events reported compared to the placebo group. And that it also includes a higher proportion of related adverse events than the placebo group. However, when you compare serious adverse events, related adverse events, withdrawals due to AEs and deaths, you can see that the rates are very similar between both groups. Now, if we break these data down by system organ class from dose 1 to the unblinding date, what we see is a similar pattern that we've observed before in the EUA. So you can see the top 4 categories from general disorders down to gastrointestinal disorders account for the major differences in adverse events between the vaccine and placebo. And if you examine the adverse events individually in each of these system organ classes, what you find is that the imbalance is due to reactogenicity events being reported in those who did not have the benefit of an e-diary. So for example, in the general disorders and administrative site conditions, those mostly reflect local reactions at the injection site and systemic reactions of fever and fatigue. Whereas in the musculoskeletal and connective tissue disorders SOC, it came from arthralgia and myalgia. In the nervous system, it was primarily headache, and in the gastrointestinal disorders, it was nausea and diarrhea. However, there were other adverse events that we felt were reported at a higher frequency in the vaccine group compared to the placebo, and this is represented on this slide. So on the left, you see the adverse events that were reported at a higher frequency, from pain in the extremity to hyperhidrosis, which is excessive sweating. And if we focus on pain in the extremity for a moment, you can see that there were 185 individuals who reported pain in the extremity compared to 44 in placebo. And when we looked at the analysis on when these adverse events were occurring, what we found was that they were really clustering within 7 days after the first or second dose. So you could see with pain in the extremity, there were 88 7 days after the first dose and 84 7 days after the second dose. So our interpretation of these data is that since these adverse events were clustering within 7 day period after each dose, they are considered to be attributed to the experience of reactogenicity and plausibly associated with local reactions to systemic events. Now let's turn our attention to serious adverse events with an incidence rate greater than 0.1 event per 100 patient years. Focus your attention on the list of SOCs for adverse events along the left-hand column, and then the vaccine compared to placebo in the following columns. So you can see for any serious adverse event, there were 268 reported in the vaccine group, which calculated out to an event rate of 3.2 per 100 patient years, and there were 268 in the placebo group, which calculated out to an event rate of 3.3 per 100 patient years. And if you glance down the columns that are highlighted in red, what you can see is that the event rates, vaccine or the placebo group, are very similar. In terms of related serious adverse events, are presented in this slide. There were 4 serious adverse events attributed to the vaccine and 1 to the placebo. All 4 of these have been previously discussed at the time of the emergency use authorization. So we did not capture additional SAEs from dose 1 to the unblinding date in this data set. There was 1 related psoriatic arthropathy that occurred in the placebo. And now if we look at deaths from dose 1 to the unblinding date, I call your attention to the top row. For all deaths, there were 15 deaths reported in the vaccine group, and there were 14 deaths reported in the placebo group. The incidence rate was 0.2 for both the vaccine and the placebo group. And you can look down at the individual events, and you can see that they're essentially one-offs in each of the categories. And here's the following slide. This lists all of the deaths in the study. So now let's turn our attention to adverse events for the data cutoff. So this data represents dose 1 to 6 months after dose 2 in vaccine recipients. So here you can see the overall adverse events from dose 1 to 6 months after dose 2. On the y-axis, again, is the frequency of those reporting at least one adverse event. And on the x-axis, you see various categories of adverse events. And I'd like to remind the committee that we saw previously that there were about 32% that reported any AE, and now that compares to the 28.8% that are reporting any AE in those with 6 months of follow-up. Similarly, related adverse events were reported in 18.7%, and again, that compares favorably with the 24% I showed several slides before. We'll look at any SAE, related SAE, withdrawal due to AE, and death. You can see that these rates remain low with the additional follow-up time. If we were to break these adverse events by system organ class from dose 1 to 6 months after dose 2, what we see is what we've seen repeatedly in this study, which is most of the adverse events are being concentrated into the general disorders and administrative site conditions, musculoskeletal nervous system, and gastrointestinal disorder systems. And if we were to evaluate the individual adverse events, what we found is that we see the same sort of local and systemic reactogenicity in these categories being reported by individuals who did not have an electronic diary. Now, if we look at serious adverse events greater than 0.1% by system organ class from dose 1 to 6 months after dose 2, you can see that there were 190 events, or 1.6% of the subjects reported serious adverse events in over 12,000 individuals. And if you just glance down the column, what you see is that the rate and proportion of serious adverse events was low in all of the different categories. Let's talk about adverse events of special interest and other important terms evaluated during the placebo-controlled portion of the clinical trial. So we evaluated hypersensitivity anaphylaxis during the blinded control period and found that there were 3 SAEs in that category. One was due to a bee sting, one to an antibiotic, and one to an ant bite. However, in the open label follow-up period, there was one subject who reported an anaphylactoid reaction assessed as related to vaccine. This was in a teenager with a history of multiple allergies who developed the event 2 days after dose 3 in the study, which is really the first dose of vaccine. She had hives. She self-administered epinephrine, and the event resolved 10 to 30 minutes later. This was not medically attended. Importantly, the participant received a second dose of vaccine outside the study 40 days after the first, and no allergic reaction was reported. We also evaluated Bell's palsy. So on this table, I am presenting all of the cases of Bell's palsy reported through the 13th of April. And what we see is that in the placebo-controlled portion of the trial, there were 4 cases of Bell's palsy in the vaccine group compared to 2 cases in the placebo group. When placebo patients were able to receive vaccine and crossed over to vaccine, there were 3 additional cases that were reported after the crossover. And then there was 1 additional case that was reported and who was originally randomized to vaccine and reported the Bell's palsy with additional follow-up. You can see that there's an roughly equal distribution of men and women with an age distribution from 19 to about 73. And in terms of days from the last dose, you could see that there was a bimodal distribution where some of the cases were occurring close to vaccination, while others were occurring more distant to vaccination. And of course, all of the cases that occurred proximal to vaccination were labeled related by the investigator in this analysis. I would also like to point out that 3 of the subjects had risk factors for Bell's palsy. 1 subject had diabetes. 1 subject had a history of Bell's palsy and a transient ischemic attack. And another subject had 3 episodes of Bell's palsy in the same distribution. She had it when it was reported in the trial. We found a higher rate of lymphadenopathy reported in the vaccine group compared to the placebo, 0.4% compared to 0.03%. We also evaluated appendicitis. We found 15 cases of 0.7% compared to 12 cases in the placebo group of 0.6%. None of these were related to study intervention by the investigator. We also evaluated angioedema and hypersensitivity. Overall, we found that there were 30 cases of 0.14% in the vaccine group versus 29 or 0.13% in the placebo group. In terms of hypersensitivity, these events were mostly characterized by rashes, which were maculopapular or papular. There were similar rates between vaccine and placebo. We evaluated demyelination. There were 2 cases of optic neuritis in the vaccine group compared to none in the placebo group. In both cases, they had convincing evidence that they had optic neuritis and were treated with appropriate doses of steroids. But please note that in one case, the optic neuritis occurred 80 days after the last dose, and in the second, it occurred 103 days after their last dose. There was one Guillain-Barré syndrome, and that occurred in the placebo group. We also evaluated a large number of terms in the study, and they're happy to report that none of them were reported in the study as of the time of the cutoff. You can see from the list that most of these are neurological events, and some are hematologic events, and some are pulmonary events. There were 2 cases of bacterial meningitis reported in the study with the bacteria identified in those cases. We evaluated acute myocardial infarction. Overall, we found that there were 11 events reported to the vaccine and 17 events reported to placebo. Most of these events had onset distant to, in other words, 30 days following receipt of vaccine or placebo. None of these events were assessed by the investigators related to study intervention. Outcome was fatal in 2 participants in the placebo group, and resolving in the other cases. There were 2 cases of encephalopathy reported in the vaccine group and none in the placebo group. In the first case, it was a toxic encephalopathy due to infection, and in the second case, it was uremic encephalopathy. There was 1 multisystem inflammatory syndrome reported in an unfortunate subject who developed multi-organ dysfunction secondary to COVID-19 in the placebo group. For myocarditis, there was 1 case in the placebo group. I believe this group knows well that there was an additional myocarditis case reported in the vaccine group after we submitted this data. This case has been well discussed. The only follow-up I have is that the case has completely resolved. There was 1 event of pericarditis in the vaccine group in an elderly man that occurred 29 days after dose 2. And this was thought to be not related to study intervention. For pulmonary embolism, there were equal cases in the vaccine and in the placebo at 8 apiece. For hemorrhagic strokes, there were 4 cases in the vaccine and 3 in the placebo. For ischemic stroke, there were 8 cases apiece in the vaccine and in the placebo. For thrombocytopenia, there were 2 cases apiece in the vaccine and the placebo. For both of the vaccine cases, there was a reasonable medical event that is causally related to the low platelet count. In the first case, there was alcoholic cirrhosis, and in the second case, it was secondary to sepsis. For venous thromboembolism, there were 9 cases in the vaccine and 9 cases in placebo. None of these events were associated with thrombocytopenia. In terms of pregnancy, I want to remind the group that you had to have a negative pregnancy test to get vaccinated. So most of the cases occurred well after vaccination. Overall, we found that there were 42 women who got pregnant in the vaccine group compared to 47 in the placebo group. 5 apiece withdrew from vaccination due to pregnancy. The majority of these subjects completed 2 doses of vaccine. And additionally, most were more than 30 days after their second dose when they got pregnant. In terms of spontaneous abortions, there were 3 in the vaccine group and 7 in the placebo group. There were 3 miscarriages in the vaccine group and 5 in the placebo group. And then in terms of elective abortions, there was 1 in the placebo group, and there was no reports of fetal demise or major birth defects as of the cutoff date. I would add in extensive analyses that was done post-marketing, including clinical trial cases and pharmacovigilance analyses from across the globe. To date, there has not been any evidence that the vaccine impacts fertility or has major birth defect outcome. Let's talk now with efficacy data. As you all remember, our primary endpoint occurred 7 days after the second dose. You're looking at the analysis in subjects without evidence of infection prior to 7 days after dose 2. There were 77 cases in the vaccine group compared to 833 in the placebo group, which calculates to a vaccine efficacy of 91.1%. And now if we look at individuals with or without evidence of infection prior to 7 days after the second dose, there were 81 in the vaccine group, 854 in the placebo group, with a vaccine efficacy of 90.9%. And now if we look at efficacy broken down by various demographic groups, such as age, sex, race, ethnicity, and country, what we find is that overall vaccine efficacy was 90.9%. And no matter how we cut and slice the data from the various demographic groups, we are reporting high values of efficacy across all these demographics. And in the vast majority of the cases, we have tight confidence intervals well above 0. Additionally, we did an analysis with and without evidence of infection prior to 7 days after the second dose. And here we looked at people who were at risk for COVID-19 due to a comorbidity. A comorbidity was defined as at least one of the Charleston Comorbidity Index or obesity. And then we further divided this by whether the subject was at risk and then at risk within various age cutoffs, obese, and then whether they were obese in various age cutoffs. Overall vaccine efficacy was 90.9, and no matter how we looked at this, we found high estimates of vaccine efficacy across all risk factor groups, tight 95% confidence intervals. Now here's the first COVID-19 occurrence after dose 1. So this analysis will include anyone who got a diagnosis of COVID-19 that could occur immediately after dose 1 until the end of the analysis. So when you include those cases, vaccine efficacy is estimated to be 87.8%. However, when we stratify the analysis starting at greater than or equal to 11 days after dose 1 to before dose 2, vaccine efficacy increases to 91.7. Dose 2 to 7 days after dose 2, you see it's 91.4. And then as we increase time from that second dose, from 7 days to 2 months, and then from 2 to 4 months, and then greater than 4 months, you could see that vaccine efficacy remains high, and our latest value is 81.3%. In terms of severe COVID-19, this is subjects without evidence of infection prior to 7 days after the second dose. There was 1 case in the vaccine group, 21 cases in placebo, which calculates out to a vaccine efficacy of 95.5%. When we repeat the analysis using the CDC definition of vaccine efficacy was 100%. Now here is the analysis of the breakthrough cases that occurred in the study. So let me orient you. Along the left-hand column, we see variants of interest or variants of concern. And then we see in the next 2 columns, vaccine and placebo with the total. The first point I would like to make is that what we were looking for here is whether there were imbalances in variants of concern that was overly represented in the vaccine group compared to the placebo. And so what this analysis is showing is that the vast majority, or 86.1% of the sequences that were identified were categorized as other, meaning that they were neither variants of interest or variants of concern. And if we looked at the variants of interest and concern that were actually reported, you could see that the proportions between the vaccine and the placebo were relatively similar. And this is why we concluded that there is no apparent SARS-CoV-2 lineage pattern among vaccine breakthrough cases that would suggest meaningful reduced vaccine efficacy against any variant through the 13th of March 2021. But please note that at the time of the analysis, there was no Delta variant identified. So overall, conclusions in our phase 2-3 study, updated efficacy analysis continues to show that the vaccine at 30 micrograms provided a high level of protection against COVID-19. This was shown in participants across various demographic subgroups. Severe cases were observed primarily in the placebo group. The tolerability and safety profile of the vaccine in participants 16 years of age and up to 6 months after the dose 2 was acceptable throughout the follow-up period to the data cutoff and consistent with results previously reported. That ends my discussion, and I would be happy to take questions. Thank you.
Thank you, Dr. Perez, for that informative presentation. This presentation, or this session actually, is now open for questions. And I'll look to the chat. Dr. Paling.
Dr. Perez, thank you for this very important presentation and reviewing both the safety and efficacy. I wanted to ask for clarification. Early on, you talked about safety and showed 4 events: lymphadenopathy, ventricular arrhythmia, and 2 others. I wanted to give you an opportunity to expand on the conversation about the ventricular arrhythmia that was reported on that slide. Thank you.
Talk if it's important, sure.
If folks will please mute their lines, and we'll ask Dr. Perez to respond.
Thank you for the question. This was in an elderly individual who had a history of arrhythmias in the past, pacemaker, and other cardiac issues, who developed the ventricular arrhythmia a few days after receiving the vaccine. Overall, it was felt that these events that occurred in the subject were due to her ongoing cardiac issues, and hence, we believe that that's a reasonable explanation for what has happened.
Thank you. Dr. Sanchez?
Thank you. And thank you for that presentation. I have a question. Do you have any data on antibody levels, spike protein antibody levels, on those who who were infected with COVID, whether it was mild disease or severe disease, and certainly within among those who required hospitalization or time? That would be that's important as we try to figure out what is the actual antibody level that might be protective.
Unfortunately, we don't have an analysis as you have specified. We have phase 2 immunogenicity data for those phase 2 subjects, and we have booster data for people who were in that portion of the trial, but not in the breakdown that you have requested to date.
Do you have that data available, or so that it could be looked at in the future, or was that not collected from the study?
We would have to go back and see if we can do that analysis with the data that we have. There was no plan at this point of looking at it, but we would be certainly open to comments and suggestions from experts such as yourself.
I think it would be important data to have. Thank you.
Take that back to the team. Thank you.
Thank you. I'll just take a moment to emphasize, I do think correlates of immunity will be incredibly important. Dr. Sanchez, is there anything else?
No. I'm trying to put my hand down.
Okay, thank you. Dr. Chen?
Good morning, Dr. Sanchez. Thank you so much for that thorough presentation. One of the very common questions I get from the community is about long-term side effects due to vaccination. And I think with your review of the safety events, largely there did not seem to be evidence of a strong association of vaccination causing any of the adverse events of special interest that you identified. There was the lymphadenopathy, which profoundly did look like there was a significant, increased risk of that event happening with vaccination. How long did the lymphadenopathies last? Were they prolonged events, or did they resolve relatively rapidly? Maybe you can just describe the kind of median duration of those events.
Most of the lymphadenopathy events really resolve within several days to a week or two. There were one or two subjects, though, that had somewhat prolonged lymphadenopathy, but typically the lymphadenopathy was at the same ipsilateral side of the vaccination, either in the axilla or in the cervical area on the same side. So it definitely occurred at a higher rate in the vaccine versus placebo group, but it really didn't impact care to any large extent.
Thank you. Are there any other questions from ACIP members or our liaisons or ex officio members? Oh, great. Dr. Long.
Yes, thank you very much. I understand the cutoff point of the data, and do I understand that these are the data that were presented to FDA for licensure as a first question? Correct. Okay.
Yes, these were.
So the second question is, it's 5+ months later, and we will have not so much related today to the vote on recommendation after full licensure, but we will want to know the data on the protection against Delta variant. And we will want to try to differentiate potential lack or decreased efficacy right off the bat compared with decreased efficacy as time away from vaccination. And it seems like you do have that opportunity, especially with the individuals who were secondarily vaccinated after they were found to be on placebo, that you will have some that were a little closer in time to the appearance of Delta, and you will have others that are quite distant from their vaccine who received vaccine rather than placebo initially. So long-winded question. Will you collect, and will we ever be able to see effectiveness against Delta?
The shorter answer is yes. We have a study 1031 that is being conducted as we speak, where we'll be looking at the immune response prior to and after boosting in a placebo-controlled manner. There will be 10,000 individuals randomized into that study. So you will have information on Delta, because obviously Delta is the major variant of concern at the time of that study being conducted.
I was specifically asking about effectiveness. We would be interested in immunogenicity, but you will also have effectiveness data.
Correct. We plan to do an efficacy analysis. The study was designed to show efficacy.
Thank you. Dr. Maldonado?
Yeah, thank you, Dr. Perez, for that presentation. I know that in the initial EUA application, there was a subcategory of patients who had previous COVID-19 disease and then were vaccinated. Do you have any updates on this new analysis around people who had been vaccinated subsequent to COVID-19 infection, and whether or not their adverse events were distinct from those who had never had COVID-19 infection prior to vaccination?
Thank you for the question. Actually, there's an extensive analysis in the BLA that I just didn't have time to get to today. So the first analysis is we took all of the subjects in the placebo group who got COVID-19, and after they recovered, we vaccinated them with our vaccine. And in addition, there was an unfortunate 5 subjects who managed to get COVID-19 twice in the placebo group, and then who got vaccinated in the study. The adverse event profile is the same as what we've seen and what we would expect from people who have never had COVID-19 before. From an adverse event, from a reactogenicity event perspective, what we see is there's slightly higher rates of reactogenicity after the first dose, but then it really decreases after the second dose. If you compare overall reactogenicity between those who are positive or negative at baseline, they look roughly the same. In terms of the adverse event analysis that we see, they're reporting, again, mostly reactogenicity after they get vaccinated. We did not identify any related SAEs, life-threatening AEs, withdrawals due to AEs, or deaths that were associated with vaccinating that group.
Thank you.
Thank you. Dr. Paling?
Dr. Perez, I want to thank you again for this presentation. I understand this is focused on the population for the BLA, but there's a lot of discussion going on as the hospitalization rate among children is increasing. And so I wanted to give you an opportunity to comment if you're going to be following the same study for the same data for children 12 to 15 years of age, and any comments on the studies ongoing for the younger population. Thank you.
Certainly. The 12 to 15-year-olds were included in this study, and we have plans to get the 6-month follow-up data on those 12 to 15-year-olds, and then do an analysis and write that up and submit to FDA for an extension of our license to include 12 to 15-year-olds. In addition, there are other studies that are ongoing now in the pediatric population, the 1007 study, where we're looking at 5 to 11-year-olds and individuals less than 5 in that study. And those data, especially in the 5 to 11-year-olds, will be coming as quickly as we can get that out.
Thank you. Do not see any additional hands raised. I want to thank our speakers. I also just want to emphasize that the committee is clearly interested in additional data on both safety and efficacy as asked by our questioners today. I will, Dr. Freihofer has one last question, and then I think we're going to take a break after this last question. Dr. Freihofer?
Thank you, Dr. Lee, and thank you for that presentation. This is a follow-up of Dr. Long's question. You mentioned study 1031 that's looking at immune response prior to and after boosters. As you know, we're all so concerned about Delta. You know, it's sort of taking over our lives. And can you give us any hint as to when that study of data may be available?
Well, the study is being recruited now, and again, it's mostly an efficacy study. It was designed to be an efficacy study. The immunogenicity will be in a subset, but I would actually have to ask some of my other colleagues to give you a more definitive date on that. Certainly, we wouldn't expect anything before the end of the year. But Dr. Gruber, could you?
Yeah, that's fine. Can people hear me?
Yes, they can.
Okay, great. Yes, I think John has sort of explained the nature of the study, and he's right that we're obviously looking at the potential for enhanced efficacy associated with the booster dose compared to the individuals that have not been reboosted. Obviously, there's several time elements all affecting when that data would be available and the potential to actually be compelled to roll those subjects over. But our current target, recognizing that this is a case accrual study, and we've just begun testing of those samples, so I don't know where we are in terms of the requisite number of cases for us to discriminate a difference. Our target is ostensibly to have the ability to look at cases by October. If it turns out, of course, we know that there's the potential for a booster recommendation by the 20th of September. That obviously will play into decisions we make about rolling those individuals over, just as occurred at the time of the EUA when we were in a position to roll over placebo subjects. So we'll have to look at all of that in the context of discussion with regulatory authorities, but I'm figuring, sort of late September, October timeframe for actually being able to demonstrate the nature of efficacy. Do keep in mind, obviously, there's a lot of other data out there from Public Health England, Israel, and there are others online, and Luis Jodar's group that could comment about that if that's of interest, that speak to the nature of not only the decline that's seen over time in efficacy for the Delta variant, but also the potential advantage of a booster. Our hope was to actually have a controlled study that would look at that, and we will get whatever data we can that will help inform thinking based on that study. But if there is a little bit of it being potentially confounded in terms of when placebo subjects would roll over.
Thank you, Dr. Gruber. And with that, I will thank our presenters once again, and the committee will now recess. We are intended to convene at 15 after the hour, but I'm going to say that we'll start again at 17 minutes after the hour. Thanks, everyone.